Imagine for a moment a hidden tax we all pay. Not, from the government, not at the checkout counter, but right inside our healthcare system. We're talking about waste in hospitals, and the numbers are truly staggering.
They really are.
Today, we're going to pull back the curtain a bit on just how much waste there is and how it impacts, well, everything.
Yeah.
From the operational costs to the actual quality and safety of patient care.
Yeah, it touches everything.
So this deep dive is all about understanding hospital waste management. We're unpacking a really fascinating research paper. It's titled Waste Management Approaches in Hospital Organizations and an Example of Practice, published in the Balkan Military Medical Review.
Right.
And our mission really is to pull out the most vital insights from this study. We're focusing on how waste gets identified, how it's measured.
And what it actually costs.
Exactly. What its true cost is, not just in dollars and cents, so that's huge,
Yeah.
but also in patient outcomes, the efficiency of care. It's about turning this complex data into something clear, something actionable for you, the listener.
And just to give you a bit more context on our source here, we're digging into a detailed quantitative research paper. It looked very closely at one specific university hospital in Turkey.
Oh.
So this isn't just theory. It's a real deep dive into how a waste identification tool was actually applied in the real world. It gives us this really granular look at the challenges, the opportunities that pop up when you try this in a live hospital setting.
So a tangible example, we can see what actually happens on the ground.
Exactly. When you really start looking for inefficiency.
Okay, let's unpack this then. Hospitals everywhere, and definitely in Turkey where this study happened, they're under enormous pressure.
Constant pressure.
It sounds like this constant tug of war for hospital managers. They're trying really hard to save money, cut those excessive operational costs.
Right.
But at the same time, they have to improve healthcare quality, make sure patient outcomes are getting better. It feels like an impossible balance sometimes.
It really does.
So how does waste management fit into that incredibly tough equation? Why is it presented as so critical, non-negotiable almost?
Well, waste management isn't just a buzzword here. It's really presented as a critical strategic intervention. It's designed to sort of smooth the severity of these intense pressures, these often conflicting goals you mentioned.
Okay.
And when we talk about waste in this study, it's important to understand we're not just talking about, physical garbage like bandages or old needles.
Right, not just overflowing bins.
Exactly. I mean, that's part of it, sure, but the definition here is much broader and maybe more insidious, actually.
How so?
Well, here, waste includes things like inefficient processes that add zero value for the patient.
Like unnecessary paperwork?
That could be one example. Or unnecessary steps in a patient's care pathway. Redundant tests, tests that give you information you already have or that won't actually change the treatment.
Okay.
And even underutilized resources. Think about expensive MRI machines sitting idle for hours.
Or empty hospital beds.
Empty beds, exactly. Or even not fully using the skills and potential of the hospital staff themselves.
Right.
So by systematically finding and getting rid of this kind of waste, a hospital can fundamentally optimize how it works.
Which affects the bottom line.
Directly.
Yeah.
It impacts how efficiently it runs, how much a patient's care ends up costing, and this is crucial, how safe and effective that care actually is.
So it's about cutting costs, yes, but it's also deeper. It's about improving the whole system.
Precisely. Improving it for everyone involved, patients, staff, the hospital itself.
And to really get a sense of the scale of this problem, we need to look beyond just one hospital or even one country, right?
Absolutely.
This paper, even though it focuses on Turkey, it references a really significant study from 2012 by Berwick and Hackbarth.
A landmark study.
They estimated the annual cost of waste just in the U.S. healthcare system at $1 trillion.
Yeah.
1 trillion with a T. It's almost impossible to wrap your head around that number.
It is. And what's fascinating here is that trillion-dollar figure, it isn't just some abstract number floating out there.
Okay.
The paper emphasizes that this huge amount represented roughly 40%, 40, of the total U.S. healthcare spending at that time, which was around $2.6 trillion overall.
40%. So nearly half of all the money spent on healthcare was potentially just vanishing into inefficiency.
That's what the estimate suggests, yes. And this quantity, this $1 trillion, it's described in the paper as a blockage potential to the reimbursement systems across the entire healthcare system.
A blockage potential. What does that mean in practical terms?
Well, think of it like this. For you, the listener, Imagine that $1 trillion not as some phantom number, but maybe. Think of it as 10,000 brand new, fully equipped hospitals.
Wow.
Or maybe a decade's worth of funding for the kind of vaccine research that could stop the next pandemic before it starts.
Okay, that puts it in perspective.
Or even just putting, say, an extra $3,000 back into every American household's pocket each year through lower insurance premiums or taxes.
Right.
It's money that's being spent, but it's not delivering real value or tangible benefit in return. It's like this massive, invisible hand just siphoning off funds.
Funds that could be used for so much more. Better care, innovation.
Exactly. Better patient care, innovative treatments, research, lower costs for everyone.
It's just incredible. And when you think about what $1 trillion in waste means globally, not just in the U.S., I mean, how does that level of inefficiency hit things like access to care in, say, developing nations, where every single dollar counts?
That's a crucial point. If such a huge chunk of healthcare spending is being eaten up by waste, it automatically means fewer resources are available for everything else.
Like direct patient care.
Direct patient care, absolutely, or research and development for new drugs and therapies, or essential infrastructure improvements in places that desperately need them.
Or even public health programs. Things that prevent illness in the first place.
Exactly. Those public health campaigns that save lives and actually reduce future healthcare costs, they get squeezed. This level of inefficiency can make existing inequalities in access to care even worse. It can slow down the adoption of new medical technologies around the world, and it can seriously limit a country's ability to respond effectively to big public health crises, whether it's a pandemic or a natural disaster.
So it's like a drag on global health progress.
It really is a systemic drag. And considering the studies from Turkey and the big benchmark studies like Berwick and Hackbarth are often from the U.S., it really suggests that waste isn't just a problem for one country or one type of healthcare system.
It's everywhere.
It seems to be a universal challenge, yeah. Something inherent in just how complex delivering healthcare is.
So if waste is this huge, pervasive issue, how do you even start to find it? It's not like there's a big flashing sign saying waste here.
No, definitely not. It's often hidden in plain sight in processes.
Which is where this paper introduces its core methodology, this specialized tool, the Hospital Inpatient Waste Identification Tool, or HIWIT for short.
HIWIT, yes.
And it comes from a reputable source, right? The Institute for Healthcare Improvement, the IHI.
That's right. They're an independent, not-for-profit group, globally recognized as leaders in healthcare improvement work. So yeah, this tool has a solid pedigree. It's not just some checklist someone whipped up overnight.
Okay. And you mentioned it was robustly developed.
Extremely. That's a really important point. It wasn't a quick job. HIWIT was painstakingly put together by a big expert team, 60 people involved. Highly experienced folks.
60. Wow.
Yeah. And crucially, it went through a really rigorous pilot study that lasted over 2 years.
2 years of testing.
2 years. So that extensive development and testing period really suggests a very solid, well-vetted approach. A lot of thought, practical testing, and refinement went into it before it was widely used. It wasn't just theory. It was tested and tweaked in real hospitals. Makes it highly credible.
Now, here's where it gets maybe a little counterintuitive for some listeners. You mentioned the foundation of HIWIT is lean service, which draws its ideas from the Toyota production system.
Correct.
Now, when most of us think Toyota, we think efficient car manufacturing, assembly lines, not really hospitals and patient care.
Right. Seems like an odd pairing at first glance.
Yeah. We think of hospitals as places of healing, human connection, not production lines. So borrowing from something designed for industrial efficiency, for healthcare, that's quite a twist. How does something built for cars really translate effectively to the complexities of caring for sick people?
It's an excellent question, and it does highlight the kind of ingenuity of the lean approach, I think.
Huh.
If we connect it to the bigger picture, lean principles at their core are all about maximizing value.
And in healthcare, value means?
Anything that directly benefits the patient, anything that helps their healing or improves their experience.
Got it.
And at the same time, lean focuses on systematically minimizing waste, which is anything that eats up resources without adding that patient value.
Okay, so applying that to healthcare.
It means meticulously looking at every process, every step, and asking, does this actually help the patient?
Yeah?
So it could mean streamlining paperwork to cut down waiting times, making sure every single action by a doctor or nurse truly benefits the patient or adds value in lean terms, identifying and removing bottlenecks in how patients move through the hospital.
So it's about creating a smooth flow, like an assembly line,
Yeah.
but for people getting better.
That's a good way to put it, yeah. Creating a smooth, uninterrupted flow of care. But the goal isn't to dehumanize it. It's the opposite, actually.
How so?
It's about delivering the right care at the right time in the most efficient and safest way possible, which improves patient outcomes and uses resources wisely. It's about optimizing the system so clinicians can actually spend more time focusing on what they do best, caring for patients, instead of battling inefficient processes.
That makes sense. Less time fighting the system, more time healing.
Exactly.
And structurally, this HIWIT tool is made up of 5 different modules, right? Each looking at a different piece of the puzzle.
That's right. 5 distinct modules. There's the ward module, the patient care module, the diagnosis module, the treatment module, and the patient module.
And they're adaptable. Hospitals can tweak them.
Yeah, they're designed to be customizable based on the specific needs of the hospital using them. And crucially, each module comes with its own detailed worksheet and very clear, comprehensive instructions.
Like a roadmap.
Exactly. A clear roadmap for implementing it, which helps ensure consistency even if different people or departments are using it.
Those detailed instructions must be vital.
Oh, absolutely crucial. They guide the people applying the tool. They clarify anything that might be ambiguous. It ensures everyone's applying it the same way, collecting data consistently. That attention to detail is what makes HIWIT a practical, usable tool, not just a concept. It provides clear guardrails for what is, let's face it, pretty complex data collection.
So how do they actually put this carefully designed tool into practice in the study we're looking at?
Well, the study used rigorous quantitative research methods. They focused on one specific place, the Research and Education Hospital of Dosi University in Turkey.
And they were on the ground for a while.
Yeah, several months. They really embedded themselves to collect the data.
Now, you mentioned earlier this was convenience sampling. What does that mean for the results?
Right. So convenience sampling means this hospital was chosen basically because it was the one that agreed to participate. It granted permission.
Ah, okay. Not because it was perfectly average or representative of all hospitals everywhere.
Exactly. It wasn't selected for its statistical representativeness. So while this allows for a fantastic, really in-depth, real-world case study,
You get lots of detail.
you get tons of detail. But it also means the specific findings, like the exact percentages of waste they found in dose, might not be perfectly generalizable to every single hospital out there.
So we can't say every hospital has 44% waste in diagnostics just because this one did.
Precisely. But, and this is a big but, it still provides incredibly valuable, tangible insights into how the HIWIT tool works in the real world. It powerfully demonstrates its potential effectiveness in a specific live setting.
So it's a really informative case study. Lots of lessons learned.
Definitely. Deep lessons on the practical side of identifying waste. And the application itself was pretty rigorous. It was carried out by a dedicated team of 3 healthcare personnel.
3 people covering the whole hospital.
Well, applying the different modules across the relevant areas. And it took place over several months, specifically between June 15th, 2012 and December 31st, 2012. So a good chunk of time to gather comprehensive data.
Okay, let's break down how they applied each of those 5 modules, because this really shows the level of detail they went into. The ward module first.
Right. For the ward module, they visited 19 different wards and units, medical inpatient wards, elective surgery wards.
19. That's quite a few.
It is. And it wasn't just a quick peek. Each ward got a focused 30-minute visit. This involved the team doing bedside rounds with the chief nurse and really scrutinizing patient records right there.
To get a snapshot of what was happening.
Exactly. A snapshot of the ward's condition, the daily operational reality at that moment. And in total, they examined 762 beds across those wards.
762 beds. That's a significant sample size for looking at ward-level stuff.
Definitely gives you a solid picture of ward utilization and potential inefficiencies there.
Okay, then the patient module. This sounds interesting, bringing the patient perspective in.
Very much so. This was done by 2 healthcare personnel, again across those same 19 wards. They interviewed 61 patients who were just about to be discharged.
What were they asking them?
They focused specifically on incidents during their hospital stay that the patients felt were not helpful or hindering recovery.
Ooh, Like what kind of things?
Well, imagine you're a patient, maybe feeling anxious or unwell, and you get asked the same questions about your medical history by 5 different people. Ugh, that would be frustrating.
Right. Or waiting hours for a medication that was supposedly ordered days ago, or maybe confusing communication about discharge plans. These aren't just minor annoyances.
No, they reflect system problems.
Exactly. They're direct reflections of systemic waste. They add stress. They can potentially delay recovery. Getting that direct feedback from patients is invaluable for seeing how these inefficiencies actually feel from their perspective.
Makes sense. What about the patient care module?
For that one, 3 healthcare personnel visited the 19 wards. They examined 154 patient records. This included all the ICU patients' intensive care, plus a random sample from the other wards.
And they did this with the nurses.
Yes, reviewed meticulously together with the bedside nurses. This module really dug into the specifics of the direct patient care activities, the actual interventions, the procedures being delivered, looking for variations or potential issues there.
Okay, then the diagnosis module. This one had the highest waste percentage later, right? It did, yeah. This module was applied by just 1 healthcare personnel, but they focused on 11 elective surgery wards and 1 emergency unit. They collected data on 5 specific types of waste related to the diagnostic process.
Just 5 types.
5 specific types defined by the HIWIT tool for this module. But what's really notable here is that applying this module correctly required extensive consultation with 2 academic physicians,
Why was that?
because they needed expert help for the accurate interpretation of waste types. It really highlights that some areas of waste, especially around diagnostic decisions, well, they require very specialized clinical judgment.
Right. It's not always black and white, waste or not waste.
Exactly. You need an expert to say, okay, given this patient's complex situation, was this test truly unnecessary or was it a reasonable precaution? It's not always a simple number. Sometimes it needs that expert qualitative assessment.
Got it. And the final one, the treatment module.
2 healthcare personnel handled this one, again, across all 19 wards. Here, they were assessing whether standardized protocols existed and were being followed for 4 key treatment areas:
Which areas were those?
anticoagulation blood thinners, glucose management for diabetes, post-operative care, and pain control, really critical areas.
Definitely.
So they observed all the patients getting treatment in those areas, and they thoroughly examined 86 patient records, looking specifically for deviations from best practices or standardized care pathways, if those pathways even existed.
Okay, so they gather all this incredibly detailed data across all these modules, identifying waste. But how did they put a price tag on it?
The costing part. Crucial step.
Yeah.
After they identified the waste proportions in each module, they did a comprehensive costing study. They used the official prices listed in Turkey's healthcare reimbursement guide. It's called the Notification of Implementation in Healthcare, or SUT for short.
SUT. Okay, so that's like the official price list the government or insurers use.
Pretty much. It dictates what procedures, tests, services hospitals can bill for, and exactly how much they get reimbursed for each one. By using those official SUT prices, the study could translate the abstract idea of waste, like an unnecessary test or an unused bed day, into concrete financial figures.
So it gives the waste a real dollar value, or lira value in this case.
Exactly. It provides that tangible financial dimension to the inefficiencies they found, and that makes the problem much easier to quantify, to prioritize, and ultimately to motivate people to fix.
Yeah, it's hard to argue with millions of dollars going down the drain.
It definitely focuses the mind. It's a difference between saying we have some waste and saying this specific type of waste is costing us X million lira every year.
Now, beyond HIWIT and its lean foundation, the paper mentioned other approaches to tackling waste too, didn't it? Just briefly.
It did, yeah. It acknowledged that HIWIT isn't the only game in town, showing the breadth of global efforts. There's the classic 7 or 8 muda approach.
Yeah.
Muda is the Japanese term for waste, originating directly from Taiichi Ono and the Toyota production system.
Back to Toyota.
Back to Toyota, it identifies 7 key types of waste. Things like overproduction, waiting, unnecessary transportation, excessive processing, too much inventory, wasted motion, and defective production.
And how does that apply to hospitals?
Well, authors have adapted it. Waiting, for example, isn't just waiting for parts on an assembly line. In healthcare, it's patients waiting hours for a bed in the ER.
Or waiting days for lab results.
Exactly. Or weeks for a specialist appointment. Each moment of waiting is frustrating for the patient, but it's also a direct cost inefficient bed use, wasted staff time. Maybe the patient's condition worsens while they wait, requiring more expensive treatment later.
Makes sense. And you said 7 or 8 MUDA. What's the 8th?
Well, the eighth one is a bit debated, but some, like the author letter, suggest it's non-used employee talent potential.
Oh, interesting. Not fully using people's skills?
Exactly, which is a powerful idea for any organization, right? It's not just about pure efficiency, it's about valuing and properly leveraging your workforce.
Definitely.
And underpinning MUDA is the concept of the 3 M's in lean production: MUDA, waste; MURI, which means excessive load or overburden; and MURA, disorder and inconsistency.
Muri and Mira.
Yeah, the idea is that MURI and MURA, overburdening staff or systems and having inconsistent, unpredictable workflows, are often the primary causes of MUDA, the waste itself. So waste often comes from system-level problems, not just individual mistakes.
Okay. What other approaches did the paper mention?
There was Choosing Wisely, which comes from the ABIM Foundation in the U.S.
Choosing wisely. I think I've heard of that.
Yeah, it's quite well known. It's a very patient-focused initiative. It aims to help doctors and patients have conversations to make smart, evidence-based decisions about care, specifically by avoiding tests and procedures that are unnecessary or sometimes even harmful.
So cutting out things that don't add value.
Precisely. Then there's what they call the use approach. Yeah, it categorizes waste based on whether care is given too much, that's overuse.
Like too many tests?
Exactly. Or too little underuse, maybe not getting needed preventative care, or incorrectly misuse, like medical errors or the wrong treatment.
Overuse, underuse, misuse. Okay.
And they also mentioned utilization management, which is all about optimizing how healthcare services are used, and the economic efficiency approach, which tries to combine technical efficiency, doing things right, with allocation efficiency, doing the right things.
Wow, so there are quite a few different lenses to look at waste through.
There really are, and it highlights that waste isn't this simple, single problem with one easy fix. These different approaches target different, often overlapping aspects of inefficiency.
From overtesting to not using staff well?
Exactly. Systemic overtesting, under-leveraging staff potential, poor resource allocation. It's a really complex ecosystem of waste. And effectively tackling it usually means you need a multi-pronged strategy, maybe drawing on several of these ideas depending on what specific problem you're trying to solve. There's no single silver bullet.
Which makes a comprehensive tool like HIWIT that looks at multiple angles seem pretty valuable.
I think that's why it's useful, yes.
Yeah.
It integrates multiple perspectives, board operations, patient experience, diagnostics, treatment into one framework.
All right, let's get into the hard numbers then. The specifics from this Dussey University Hospital study, they identified 27 specific waste types using HIWIT. What did the overall results show? Which areas were worst?
The overall proportions across the 5 modules painted a really stark picture. There was a very clear hierarchy of where the waste was concentrated.
Okay.
The diagnosis module came out on top by a long shot, a striking 44.20% waste.
Wow, 44%. Nearly half of everything measured in diagnostics was considered waste.
According to their application of the HIWIT criteria, yes. Almost half.
That's huge. What came next?
Next was the treatment module at 25.29% waste, still significant, 1 in 4.
Quarter of treatment-related activity.
Okay. Then the patient module, the one based on patient interviews, that was 16.50% waste.
16.5%.
Followed by the ward module at 11.11%.
11% of the wards.
And finally, the patient care module came in with the lowest proportion at 2.52% waste.
2.5%. Okay, quite a range there.
A very wide range, yeah.
So what does this really tell us? I mean, the diagnosis module is clearly the big elephant in the room here, isn't it?
Yeah.
You just can't ignore a nearly 50% inefficiency rate in such a vital area.
You absolutely can. It's the unavoidable headline finding. The implications are massive.
Let's dive deeper into that diagnosis module then. 44.2% waste overall. Was there one specific type of diagnostic waste that stood out?
There was. The single most wasteful type within that module was something called the metabolic panel.
Metabolic panel. That's a common blood test, right?
Very common, yes. Measures things like glucose, electrolytes, kidney function, often ordered routinely on admission or for checkups.
Okay. And the waste percentage for that?
An astonishing 83%.
83. So in more than 4 out of 5 cases where it was ordered, it was considered waste.
That's what the data suggests in the specific hospital context using the HIWIT definitions. It means in the vast majority of cases, the test was ordered when it wasn't clinically needed, or the information was already there from a previous test, or maybe the results just didn't end up changing the patient's treatment plan at all.
So it didn't add value.
It didn't add value. It's like checking the oil in your car every 5 minutes when you know it's fine. It adds costs, it adds workload for the lab, maybe a needle stick for the patient, but no actual benefit.
What does that point to? Why would it be so high?
Well, it could point to deeper systemic issues, maybe old habits, legacy practices where certain tests are just ordered automatically.
That just-in-case mentality.
Exactly, a just-in-case or cover-your-bases mentality.
Uh-huh.
Or maybe a lack of clear evidence-based protocols for when not to order these panels. And the paper does suggest, as we mentioned, that assessing waste in this diagnosis module really needs expert clinical opinion, especially for patients just admitted, within the first 12 hours. It implies that complex clinical judgment is key here. It's not always a simple tick box exercise to say if a test was wasteful or not.
Okay, so diagnosis points to sheer volume of potentially unnecessary tests. What of the treatment module, the second highest at 25.3%? What drove the waste there?
The primary driver identified there was the lack of standard protocols or clearly defined pathways for those critical treatment areas we talked about.
Anticoagulation, glucose management, post-op care, pain control.
Exactly. The absence of standardized approaches in those key domains was the main source of waste identified in the treatment module.
And the implication of that, what's the bigger picture problem when you don't have standard protocols?
The implications are huge, honestly, particularly for patient safety and just consistency of care.
Right.
Standardized, evidence-based protocols are absolutely crucial. For efficiency, yes, but even more importantly, for safety. Without them, you get much higher risk of variation in care.
Meaning different patients get treated differently for the same thing.
Potentially, yes. Or even the same patient getting slightly different approaches depending on which doctor or nurse is on shift. This variation can lead to inconsistencies, it increases the chance of errors, and as the study shows, it leads to significant waste.
How does variation lead to waste, specifically?
Well, if care isn't standardized around the most effective and efficient known method, you might have clinicians ordering extra tests just in case because they're not following a clear pathway, or using more expensive drugs when a standard protocol would recommend a cheaper but equally effective one, or keeping patients in hospital longer because post-op recovery steps aren't clearly defined and consistently followed. It introduces all sorts of inefficiencies.
So it impacts cost, quality, and safety.
All three. Standardizing care ensures patients get the best possible care based on evidence consistently and efficiently.
Okay, let's shift from the specific tests and treatments to the overall environment, the ward module. This one was lower, 11.1% waste, but you said the dollar figures were significant here.
Very significant. This is where we start seeing really tangible costs hitting the hospital's budget directly.
So what was the total cost they found just from this module?
Just using the ward module data for this one study hospital, the estimated annual cost of waste was $3,100,320.
Over $3 million
Yeah.
annually, just from ward-related waste in one hospital.
That's right. And the paper also made an interesting projection. They noted that a typical 300-bed hospital, which is a pretty common size, could potentially identify around $6 million in annual waste just using this ward module of HIWIT.
$6 million. That's serious money. What were the biggest types of waste contributing to that in the study?
The top 3 waste types identified were related to things called business capacity, unutilized capacity, and de facto capacity.
Which basically means
Fancy terms for problems with bed management and resource allocation. Essentially, beds being empty when they could or should be full, or staffed beds sitting idle, not generating revenue or serving patients. Poor flow, basically.
But wasn't there something even more critical in the ward module related to patient safety?
Yes, absolutely. Healthcare-associated infections, or HAIs.
Infections people catch in the hospital.
Exactly. Infections patients get while they're being treated for something else. These accounted for a pretty significant chunk, 13.39% of the total waste identified in the ward module.
And the cost of those HAIs?
The calculated cost was $1,049,949, just over $1 million for this hospital, just from HAIs in 1 year.
Wow. $1 million lost to infections that are potentially preventable.
Potentially preventable, exactly. And the paper highlights this concept of non-payment preventable events. Meaning if this becomes policy, and some places are moving this way, hospitals might not get paid by insurers or government agencies for the extra cost of treating certain preventable complications, like some types of HAIs.
So there's a direct financial incentive to prevent them.
A very strong one. And beyond the money, HAIs are a key measure of healthcare quality. High HAI rates are a direct indicator of lapses in safety and quality protocols.
So imagine saving over $1 million and making patients safer just by getting a better handle on infections in one hospital. That feels like a huge aha moment. It
Yeah.
shows so clearly how the financial waste and patient safety are just completely linked.
They are absolutely intertwined. It's not about pinching pennies. It's often about implementing best practices that improve safety and reduce costs simultaneously. Better hand hygiene, better sterilization, better protocols, they prevent infections, which avoids suffering, saves lives, and saves a ton of money.
Did the study break down other specific costs in the ward module?
It did, yeah. It gave some other concrete figures that paint a picture of where the money goes in operational inefficiency. For instance, empty and staffed beds cost an estimated $572,400 a year.
So beds ready to go with staff available but sitting empty.
Right. Then, empty and not staffed beds, maybe closed due to maintenance or budget reasons, still represented a cost of $205,200, presumably in fixed overheads or lost potential revenue.
Yeah.
Unnecessary hospitalization patients staying longer than clinically needed, maybe due to discharge delays or social reasons, cost $171,000.
Wow.
Flow delays, bottlenecks, waiting for tests or consults, slowing down patient movement, cost $115,200. And clinical care delays, direct medical treatments being postponed, added another $117,360.
These aren't small numbers when you add them up.
Not at all. They represent real financial drains directly linked to how smoothly or not smoothly the hospital operates. And these are things that better management and processes could potentially address.
Okay, what about the patient module? That was 16.5% waste based on patient feedback. What were patients reporting?
The key waste types identified here were described as incidents that aren't helpful and incidents that are hindering recovery.
And those made up a big chunk of patient complaints.
They did. 43% of the issues raised fell into the not helpful category, and 5% were seen as actively hindering recovery. This is powerful data because it's straight from the patient's mouth, their lived experience.
Definitely. Was there any pattern to where these issues were reported most often?
Interestingly, yes. The study found that the most waste in this patient module was encountered in the internal medicine wards and the normal intensive care units, ICUs.
ICUs. You'd think those would be highly optimized.
You might, given the critical nature of care there. But it perhaps suggests that even in these high-acuity specialized environments, there are still significant opportunities to improve the patient experience, reduce frustrations, and eliminate things that patients perceive as unhelpful or hindering. Maybe communication breakdowns or coordination issues between different specialists?
Could be. It shows even the most critical areas aren't immune to waste from the patient's view.
Seems so. Imagine being critically ill and still having your recovery potentially slowed by avoidable system glitches.
And lastly, the patient care module. Lowest waste at 2.5%, but you mentioned it was tricky to use.
That's right. Despite having the lowest identified waste percentage, the paper described this module as the most incomprehensible for the people actually trying to implement it.
Incomprehensible. That sounds problematic.
It does. They noted it needed rearrangement to better fit the specific conditions in Turkey.
So what does that tell us?
It's a really important reality check. It tells us that while a tool like HIWIT can be powerful and designed for broad use, its actual effectiveness and usability can really depend on the local context.
Like the specific hospital setup or the country's healthcare system.
Exactly. The operational nuances, the existing processes, even the culture. And critically, it depends on the training and understanding of the people using the tool.
Right. A universal tool might still need local tweaking.
Precisely. It might need localization, adaptation, maybe better training materials to make it truly effective and understandable in different healthcare settings. It's not just about having the tool, it's about how well it's integrated and understood within that unique environment.
Now, the study didn't just find waste within the 27 HIWIT categories, did it? It found other significant things that fell outside the tool scope.
It did, which is also really revealing. It underscores that waste can hide in places you're not specifically looking, or maybe in ways your tool isn't designed to capture.
What was a key example of that?
One really striking example was about ECGs, electrocardiograms, the heart tests.
Okay.
In the emergency service of this hospital, a very high percentage of patients, 85%, were getting ECGs done.
That seems high.
It does. But the bigger issue they found was in the follow-through. A retrospective look found that only 30% of those ECGs were actually formally entered into the patient records.
Only 30%.
Yeah.
What happened to the rest?
Well, the tests were done, but the documentation wasn't completed properly. This meant a loss, essentially, of about 50 ECG tests per day.
50 tests a day, just
Yeah.
lost to paperwork issues.
Lost in terms of being properly recorded and, crucially, billed for. They estimated the cost of this documentation failure at around $54,000 annually for just that one hospital, just for ECGs.
$54,000 just vanishing because the paperwork wasn't done right.
Exactly. It highlights a critical breakdown, not just potentially in clinical workflow, but definitely in the documentation and billing processes. If you don't record it properly, you can't get paid for it by insurers or the government system. It's a hidden cost driven by administrative inefficiency.
A hidden waste stream.
Definitely. And one that might be missed if you only looked at the direct clinical actions defined by a tool like HIWIT.
What else did they find outside the HIWIT categories?
They also noted the promulgated use of prophylactic antibiotics, meaning the routine, maybe unnecessary or overly prolonged use of antibiotics just to prevent potential hospital-acquired infections, sometimes keeping patients on them right up until discharge, even when there's no clear clinical reason.
Which costs money and contributes to antibiotic resistance.
Both. A double whammy of waste. And another interesting kind of paradoxical one they mentioned was not purchasing medicines that are not used for patients in due course.
Not buying medicines.
Yeah,
That sounds like saving money, not waste.
you'd think so. But the practice they described was where certain as needed or less common medicines weren't kept in stock routinely, but only ordered specifically when a patient needed one.
Okay, so just-in-time ordering, what's wrong with that?
Paradoxically, they found this practice actually increased workload, nurses having to chase down orders, pharmacy dealing with urgent requests, and it complicated overall medicine control and inventory management. So what looked like a cost-saving measure on the surface actually became a source of inefficiency and potential waste downstream.
Wow, an unintended consequence.
Classic example. A seemingly smart decision creating new, unforeseen problems elsewhere in the system.
Okay, so HIWIT identified a lot, but not everything. What was the study's overall conclusion about the tool itself? Was it deemed successful?
Overall, yes. The study concluded that HIWIT is indeed successful in classifying waste and, importantly, assessing its costs across those 5 modules and the 27 defined waste types. It proved itself as a practical tool for both defining and costing waste.
Were some modules easier to use than others?
Generally, yes. They found the ward, patient, and diagnosis modules were, on the whole, reasonably comprehensible for the implementers. People could understand and apply them relatively straightforwardly.
But not all of them.
The diagnosis and patient care modules, the ones designed to pinpoint maybe more subtle or complex waste risks, those required more guidance. More expertise was needed for the implementers to fully grasp the nuances and apply the criteria correctly.
So the tool is robust, but using it effectively isn't always simple.
Exactly. It shows that effective use often requires specialized knowledge, probably good initial training, and maybe ongoing support, especially for those areas needing tricky clinical interpretation.
Now, what's fascinating here, the paper makes a really strong point that just defining the waste, just calculating the cost, isn't enough.
Absolute critical point. Knowing is not the same as doing.
Right. It says critical action has to follow, and it emphasizes needing an expert team. But crucially, including someone from senior management.
Yes, that was a key recommendation. Establishing a dedicated expert team, but making sure it has representation from and the clear backing of senior hospital leadership. This team would lead the ongoing cost analysis efforts, but more importantly, work to improve the hospital's overall institutional capacity to deal with waste.
Yeah, that quote, something like, race calculating cannot be utilized unless.
Unless lacking support from top management is obvious. Something to that effect, yes. A very blunt statement.
It really underlines it, doesn't it?
Yeah.
Change has to start at the top. Without that visible leadership buy-in, that consistent championing, even the best data is just numbers on a page. It won't lead to action.
Couldn't agree more. If we connect that to the bigger picture, it really speaks to that gap between knowing something and actually doing something about it.
Right.
Leadership buy-in isn't just nice, it's the essential bridge. It's what turns the identified waste, the calculated costs, into actual measurable savings and real improvements in patient care. Without it, even the most meticulous studies, the best tools, they just become theoretical exercises. Nothing changes on the ground.
So management needs to not just approve it, but Actively lead it.
Actively champion it, allocate the resources needed, empower the teams doing the work, and really foster a culture across the whole hospital where reducing waste is seen as everyone's job, a continuous priority, not just some flavor of the month project.
Did the study suggest where to start? Like which areas to tackle first?
It did offer some strategic advice, yeah. Especially thinking about reimbursement agencies like the SGK in Turkey. It suggested the priority areas for immediate action should probably be the ward and patient modules.
Why those two specifically?
Because of the sheer volume involved. Remember, they looked at 762 beds in the ward module and got direct feedback from 61 patients in the patient module. These represent large-scale operations and direct patient impact. Tackling waste here could yield significant results relatively quickly.
So go for the big visible areas first. Build momentum.
That seems to be the implication. Focus on areas with the broadest and most immediate impact first. Demonstrate the value of the process.
And then?
Then, after addressing those initial priorities, the next crucial step is establishing that expert team specifically for the diagnosis and treatment modules.
The more complex ones.
Exactly. That team would then do the deeper dive needed to precisely identify and classify those more nuanced waste points, getting them ready for proper financial evaluation and targeted interventions. It's a staged, strategic approach. Tackle the big wins first, then bring in the specialists for the trickier areas.
And the paper laid out the ultimate goals, right?
Yeah.
What are you trying to achieve with all this waste study?
Yes. It clearly articulated 4 core objectives, which really sum up the why.
What were they?
First, simply improving overall performance, making the hospital run better.
Okay.
Second, diminishing operational costs, saving money.
Makes sense.
Third, shortening operational cycles, which basically means getting patients through the system more efficiently, reducing delays and length of stay.
Better flow.
Better flow, exactly. And fourth, and critically, improving patient safety.
Performance, cost, cycles, safety. The 4 pillars.
You could say that. And it raises an important point. While all 4 are vital, the study specifically suggested that the diagnosis, treatment, and patient care modules are likely to contribute more directly and significantly to that 4th goal, patient safety.
Okay. So tackling waste in those specific areas has a bigger safety payoff.
That's the implication. It highlights how targeting certain types of waste can have a very direct, measurable impact on patient well-being, beyond just saving money.
Can you give an example?
Sure. Think about the diagnosis module again. Reducing unnecessary tests isn't just about the cost of the test itself, it's about reducing patient exposure to maybe unnecessary radiation, like from CT scans.
Or avoiding false positives.
Exactly. Avoiding false positives that cause anxiety and lead to even more unnecessary, potentially invasive follow-up procedures. That's a direct safety benefit.
Right.
Or in the treatment module, standardizing protocols for things like anticoagulation or glucose management directly reduces the risk of medication errors or poor outcomes. That's a huge safety improvement.
So it really drives home that this isn't just about the hospital's budget. It's fundamentally about delivering safer, higher quality care, enhancing the patient experience.
Absolutely. The financial savings are often a very welcome byproduct of making care safer and better.
Wow. Okay, we have covered a lot of ground here. We've taken this deep dive into the, frankly, surprisingly extensive world of hospital waste.
It is surprisingly big, isn't it?
It really is. We explored this HIWIT tool that helps hospitals systematically uncover it, and we've examined the staggering costs, both the huge financial numbers and the equally important costs in terms of patient safety and the quality of care they receive. From empty beds just sitting there, to countless unnecessary diagnostic tests, to those devastating and costly healthcare-associated infections, and the problems caused by not having standardized care. The layers of inefficiency are just profound.
And deeply interconnected.
Deeply interconnected, yeah. And they affect every single one of us who might, need hospital care at some point.
Our goal today really was to give you, the listener, a shortcut to being well-informed on this pretty critical topic, to provide some of those aha moments about something that impacts us all, whether you work in healthcare or you're a patient or just a taxpayer funding the system.
Right.
You hopefully now have a clearer, more granular understanding of how this waste doesn't just hit hospital budgets, but directly impacts the quality of care people receive and the fundamental safety of patients, and also how powerful proven tools like HIWIT are actually being used out there on the front lines to systematically fight back against these pervasive inefficiencies.
So as you go about your day, here's something to maybe mull over. Given that just one hospital, like the one in this study, can identify millions of dollars in waste,
Hmm.
and the global figure is estimated in the trillions. What do you think is the single biggest barrier stopping the widespread adoption of really effective waste reduction strategies in healthcare everywhere?
Ooh, good question.
Is it a lack of tools like HIWIT? Is it just a lack of awareness? Or is it something deeper, maybe cultural resistance or misaligned incentives?
Lots to think about there.
And maybe think about this too. How might you, as a patient or just as a healthcare consumer, how might you inadvertently contribute to this waste? Or perhaps more positively, how could you help mitigate it in your own interactions with the system?
Mm-hmm.
Maybe by asking more questions, asking if a test or procedure is truly necessary, or simply by being more informed about your own health and care.
Definitely something to ponder.
Something to ponder until our next deep dive.